This episode of JNM Podcast is sponsored by Sophie Biosciences.
Hello, my name is Ken Herrmann. I'm a nuclear medicine physician based in Essen, Germany. It's my great pleasure to welcome you to the new edition of the JNM podcast. And today we're going to talk about NETTER-2 and everything which is attached to this. And for this, I have two absolutely experts today invited. And it's my big pleasure to introduce you to both of my panelists today. And first of all, I want to introduce you to Professor Dr. Simron Singh. He's a medical oncologist and affiliate scientist in the Odette Cancer Research Program at Sunnybrook Research Institute in Toronto, in Canada. He's also a full professor at the University of Toronto. He completed his Bachelor of Science and MD at the University of Alberta in Edmonton. He did his postgraduate training in internal medicine at Queen's University in Kingston and also medical oncology at the University of Texas. After completing his clinical training, he also completed his master's degree in public health from Harvard University in Boston. Welcome, Simron.
Thanks, Ken.
And the second speaker is also very famous to the nuclear medicine community. It's Professor Lisa Bodei. She is currently the Director of Targeted Radionuclide Therapy at Memorial Sloan Kettering. She joined Memorial Sloan Kettering in 2016, and obviously by her name, she has her roots in Italy. So she has an MD degree from the University of Pisa. She also had a PhD from the University of Groningen in the Netherlands. She completed her residency in Pisa and then actually joined for a fellowship the famous Institute of Oncology in Milano, Italy. And as we all know, she's one of the most renowned nuclear medicine physicians in the field of neuroendocrine tumor therapy. Welcome, Lisa.
Thanks.
And to jump right into this, it's my great pleasure to ask the first author of the recent Lancet publication of the NETTER2 study, Simron Singh, to summarize very quickly the nuts and bolts of the NETTER2 study.
Thanks, Ken. Happy to. So NETTER2 was the first trial to look at radioligand therapy really in any cancer as first-line therapy. Radioligand therapy is really picked up in neuroendocrine, especially in the GI neuroendocrine, as being one of the very important parts of our armamentarium of how we treat our patients. As time's gone on, we've understood neuroendocrine cancers somewhat more efficiently, and we recognize that there is, although the common knowledge to many non-neuroendocrine treaters would be these are slow-growing cancers, they don't need aggressive treatment. We know that that's not always true, and that there are these certain well-differentiated high-grade tumors, including this new entity described of a well-differentiated G3. And so we don't have a standard of care for this until this point. Of course, PRRT came on this landscape in the neuroendocrine community with NETTER1 and really became the standard of care, especially in small bowel and pancreas after somatostatin analogs. NETTER2 was slightly different. It looked at first-line therapy of patients who had higher grade 2, and that was defined by Ki-67 of 10% or above, or well-differentiated G3, up to a Ki-67 of 55%. Patients were randomized in a 2-to-1 fashion to receive 4 cycles of Lutathera or high-dose octreotide, 60 milligrams IM every 28 weeks. These patients were treatment naive. They were allowed to have a few doses of octreotide, just allowing for the referral patterns, but they weren't allowed to have any progression. So generally, these were treatment naive patients, and they were allowed from anywhere in the gastrointestinal tract. The treatment arms were really fairly well balanced. It was slightly over half of the patients were pancreas, and that would be expected in a more aggressive population for sure. The breakdown between G2 and G3 was about 2-to-1, and the median Ki-67 index was about 16 to 17 in the arms. The final findings showed a hazard ratio of 0.21. The median PFS in the Lutathera arm was 28.4 months. 8.5 months in the high-dose octreotide arm. There is also a retreatment phase and an extension phase, but I won't get into that today. From a safety point of view, no new red signals found at this point in terms of safety. The most common safety findings were generally the most common safety findings were nausea, diarrhea, and abdominal pain, as would be expected between these two treatments. At the time of reporting the primary analysis, there was one case of MDS, but again, this is early, and as I'm sure Lisa will talk about, we need to follow this moving forward to really understand the full impact of first-line PRRT. So far, though, no new signals. The nice part about this is the response rate. The response rate was 43% with a number of CRs as well. We had over a 5% CR rate. This was an exciting finding in this patient population, probably higher than I probably would have anticipated going into the trial. This is obviously independent of the control arm, this high response rate, so that to me is very exciting. The other piece I should mention, just because I'm sure will come up in discussion, is the G2s and G3s. We were able to do a good subgroup analysis on this and showed that both the G2s and G3s did seem to favor first-line radioligand therapy, a hazard ratio of 0.31 with the G2s and 0.27 with the G3s. And this was also constant for the pancreatic and small bowel neuroendocrine tumors, hazard ratios in the 0.3 to 0.4 range for both pancreatic and small bowel neuroendocrine tumors. So that was a reassuring finding that we had, that this effect seemed to go across the grades as well as across the primary site.
Thank you, Simron, for this very concise summary. Lisa, from a nuclear medicine perspective, what would you like to add?
Well, I would like to add that the NETTER2 study confirmed the tendency, which is part of a sort of global learning curve, of moving somatostatin receptor targeted radiotheranostic treatment earlier in the natural history of gastroenteropancreatic neuroendocrine tumors. And the study de facto provided a prospective randomized evidence of the efficacy of the practice, which is in use in several pioneeristic centers in Europe, Australia, and Asia, of recruiting earlier stage, sometimes even first-line patients. Now, from the nuclear medicine perspective, the results confirmed the relevance of radiopharmaceutical therapy with lutetium-labeled octreotide in neuroendocrine tumors, not only as a last resort, as it was presented to the community initially as sort of Hail Mary, but as a valid and efficacious tool as first line, even in aggressive, high G2s and G3 well-differentiated neuroendocrine tumors.
So we very often tend to use the term practice changing. Now my question to the two experts of you, also looking at from different perspectives, is this a truly practice changing trial, Simron?
And I'll say we don't have any evidence before NETTER2 of what's the best treatment for well-differentiated G3 tumors. These patients do not benefit from platinum-based chemotherapy. We do know that they may benefit from alkylating-based chemotherapy, although we don't have such large numbers here. So I would certainly say that this has influenced the way that we treat these high-grade tumors. And to date, it's the most comprehensive, largest trial that tells us how to treat these tumors. I completely agree with Lisa. I think what we're seeing here is we are understanding how important radioligand therapy is in the treatment of neuroendocrine tumors, especially the aggressive ones, and moving it away from, we've run out of other options, let's start to think about using this treatment, to really understanding that this can be a very effective treatment for those patients who have the right receptors, which in this case, many of these patients still had with SSTR positivity.
So Lisa, you also have your roots in Europe, so please comment both from the European as well as from the US perspective.
Yes. Well, first of all, let me say that there's a different perspective in the US compared to Europe, because at the moment, Lutathera is approved in gastroenteropancreatic neuroendocrine tumors regardless of grade in the United States, as opposed to Europe, where it is only approved for G1 and G2 tumors. So this provides evidence that Lutathera, lutetium dotatate PRRT, can be utilized with confidence in G3 tumors, not just in G1 and G2. So the results obviously provide the community with another therapeutic tool in the armamentarium of our patients, and it will modify the guidelines. So, for example, the NCCN guidelines now will have a much more granular definition of the way to proceed in higher grade neuroendocrine tumors. Also in Europe, these results will lead to a guideline change, not only in terms of position in the algorithm for G2 and G3 neuroendocrine tumors, but also the possibility of using, hopefully soon, PRRT in G3 neuroendocrine tumors.
Ken, there's one thing I wanted to add as well, since we're discussing this, and I think Lisa brings up a very good point about how we've divided neuroendocrine tumors to date. I'm speaking from a neuroendocrine point of view here, into the G1, G2, and G3. This has been our sort of our mantra of how we divide these people up into these camps, as if somebody who has a Ki-67 of 18% is somehow a different patient than someone who has a Ki-67 of 22%. Ki-67 has been the best marker we've had for predictive and prognostic reasons when we started to design these systems. But I think we also need to recognize in 2024, we probably are starting to go beyond just Ki-67. It's still a valuable marker, but we are probably going beyond that, recognizing there's a spectrum of patients with neuroendocrine tumor. And maybe we need to start thinking about things like SSTR positivity is what's important here, the uptake and the degree of the marker we use. We're seeing the same thing we're doing when we talk about lung cancer. We're talking about 14 different diseases or more based on their mutations, their marker expression. Colorectal cancer, we're moving into, is it a MED, is it a BRAF? I think we need to start thinking in neuroendocrine tumors beyond these strict definitions of G1, G2, G3. These are often based on a biopsy that was done many years ago, maybe when the disease was somewhat different. It could also be that it was a sample of a heterogeneous piece of tumor. So I think we need to think about all those things as we start to think about this treatment. And this to me is really important as well, because from the oncological, as a medical oncologist, I think it's important that our oncology community, those who use other forms of treatment, start to understand that this is going to be, in neuroendocrine cancer and in subsequent cancers, a very important part of how we treat cancer. We always like to think as the oncology community of cancer as surgical oncology, radiation oncology, systemic. We need to start moving beyond that and start to understand that this, there's new treatments that are coming that are going to change the way we think about this common paradigm.
And if I may add on to that, moving away from the biopsy, which is a photograph in time, as you said, Simron, at that particular time of that particular component of the neuroendocrine tumor disease, now with the tools offered by molecular imaging and therapy, we can characterize the disease as a whole in real time, and not just with somatostatin receptor expression, but also with FDG avidity, just to name one of the additional characteristics of neuroendocrine tumors.
I will definitely come to this, Lisa, later. For me, still, it's fascinating that if you have a cake and you take one little piece out of it and you think it's representative for the whole cake, is still for me something which strikes me. But before we come to this in detail, I want to come back, Simron, to you. During the review process, one of the, let's say, biggest pushbacks of the study was the comparator arm. Would you like to comment very quickly on the comparator arm?
Sure. I think there's a couple things that we should keep in mind. When we design a study, we have to use the best available evidence at the time. So when we designed this study, there was no prospective evidence of chemotherapy in this patient group. Although it can be used and we have seen responses, the only prospective data we have in this patient group is part of the E2211 trial looking at capecitabine temozolomide. That was an intergroup trial of 80 patients, or 80 plus, slightly more than 80. And this was the only prospective data we have, and this came out after the design of NETTER-2. NETTER-1 looked at a high-dose somatostatin analogs as a control arm, and NETTER-2 followed along. This was a patient group that was chosen to have very high SSTR expression. It was very clear that we want patients on this trial who have high SSTR expression. So I really think having a control arm of a high-dose SSA is a quite reasonable control arm in this situation, especially given the context. We also see the response rate. The response rate is independent of the control arm. We're seeing a very high response rate. To me, that gives validity in terms of understanding this response. We actually saw that the high-dose somatostatin analog arm at about 8.5 months, which again shows that there is some activity, but it's based on the receptor, right? We're targeting the receptor. We just happen to target the receptor better using radioligand therapy. And finally, I think the last piece is what's nice is we have the COMPOSE trial as well, which I think if we look at the two pieces together, they're going to add up very nicely to fulfill the picture. The COMPOSE trial now to me is sort of flipped on itself in that we now know that PRRT works in this patient group. That's pretty clear. What we don't know is if we use chemotherapy, how well does it compare to PRRT? And I think the COMPOSE arm will be a nice second piece to add to this, and we'll get a bigger picture of how that might look.
So Lisa, do you want to comment very quickly on compete and compose? Maybe not all the listeners know exactly the differences in the comparator arm.
So these are all timing studies. So studies aimed at finding the position of radiolabel somatostatin receptor agonists in the therapeutic algorithms of neuroendocrine tumors. So in a timeline fashion, NETTER-1 established lutetium dotatate as a more efficacious treatment in mid-gut neuroendocrine tumors who progress to standard dose octreotide LAR. The COMPETE study, which has completed the enrollment, but it's not finalized yet, is at the same level of the NETTER-1 trial. So it is aimed at establishing the efficacy of PRRT with lutetium dotatate in a general setting of progressing G1 and G2 disease again, but it includes all progressing gastroenteropancreatic neuroendocrine tumors and compares with everolimus. For both studies, for all studies, PFS is the primary aim. So basically, the NETTER-1 and hopefully soon the COMPETE study set the stage. Now, the NETTER-2 came and demonstrated what we learned, that lutetium dotatate is efficacious in controlling the disease and producing, elongating the progression-free survival in a much greater fashion compared to somatostatin analogs in high dosage. Now, the COMPOSE trial has been designated with a similar aim to, but in my view, it portrays a more realistic scenario for high G2 and G3 tumors, since the comparator arm of lutetium dotatate includes chemotherapy with either CAPE-TEM or FOLFOX, or everolimus, or biotherapy with everolimus, and according to the investigator choice. So in my view, this is a much higher bar to surpass. And if the study is positive, it will definitely enlarge the possibilities of PRRT.
These are very simple and maybe a little bit nasty question, but on one side we have lutetium dotatate, on the other side we have lutetium dotatate. There are subtle differences. Would you call them bioequivalent, or what would your message be there?
When we started these treatments 30 years ago, 25 years ago, everybody was very careful in utilizing and defining the differences in affinity, which is nothing else than a difference in affinity. Dotatate or octreotide has a higher affinity for SSTR2, whereas dotatate has a slightly lower affinity for SSTR2, but meaningful affinity for SSTR3 and 5. In reality, clinically, they are bioequivalent, I would say. There are no meaningful differences.
I fully echo your opinion there. Simron, we have heard about NETTER-2, NETTER-1, NETTER-2. Is there going to be NETTER-3, and what would it look like, or could look like?
Yeah, I think it's interesting. I hope there is, because again, I'd like to, I think what we really want to do is start thinking about these tumors beyond the G1, G2, G3s. And I like to start thinking about these tumors, thinking about the targets that we have, like we are in the rest of oncology, and how can we target these patients. So looking a little bit more independently in terms of trying to think about those patients who may have risk factors that we feel uncomfortable about, bulky disease, a higher tumor growth rate, potentially the possibility of large lymph nodes, or et cetera, and then thinking if we can target the SSTR2 earlier in the treatment algorithm. So I'm hoping that NETTER-3 would somehow be able to help us move that. I find the fact that we can move this into a more of an oncological field rather than simply a niche area, and then continue this journey that it's making towards being a very important part of oncology treatment. I also think, these trials are really important for the oncology world, my colleagues, for them to, the patients my oncology colleagues who don't treat neuroendocrine cancers, but I mean, obviously the ones who treat prostate now, but also the ones who treat breast cancer and HCC and gastric cancer, they need to also start to be aware of these treatments, because this is going to be an important part of how we improve our patients' care. We make big steps in cancer using this methodology, and I think it's important.
Thank you, Simron. So, Lisa, when you follow Wall Street and all the investor journals, lutetium and beta emitters are so yesterday. Everyone talks about alpha emitters. I would like to have your opinion. There are obviously also some interesting trials with lead and actinium. But like in 2 or 3 sentences, what is your view there?
So, alpha emitters, which are emit much stronger particles, actually nuclei, which travel a lot less in tissues, are becoming the the future. And preliminary studies have demonstrated the great therapeutic potential of alpha PRRT in advanced situations. Again, the same learning curve in lutetium refractory or Y90 refractory neuroendocrine tumors. So now prospective studies have been conducted with lead 212 dotamtate, demonstrating over 80% objective responses with excellent tolerability profile. Actinium dotatate has been experimented in Germany. You teach me that, and you have demonstrated responses. Although there was some concern about marrow toxicity that prompt a careful readjustment of the administered activity. Currently, we have the Action 1 trial, which is ongoing, which is actinium dotatate versus best standard of care. We are in the phase 3 component of the study, and at the moment, from the phase 1b, we know that this tool has an excellent demonstrated excellent responses and great tolerability profile. Now, with stronger isotopes such as alpha emitters, the old spectra of renal and marrow toxicity, which we knew from the initial experience of PRRT with Y90 dotatate, may appear again. So it is possible, in my opinion, that also in neuroendocrine tumors, we will end up benefiting from the experience in Germany of prostate cancer treated with PSMA targeting agents. In this setting, patients are started with a lutetium-based PSMA treatment and then proceed with actinium-based PSMA if the disease is escaping control, and this helps reducing the side effects such as severe dry mouth. Also, I would like to make two considerations about alpha therapy. And whatever therapy we're doing, we need to go back to the basics for neuroendocrine tumors, which are the dosimetry. Alpha emitters can be imaged and can be quantified, and also the calculation of the radiosensitivity or radioresistance, both for the tumor and the normal organs. I would like to see a world where we go away from the famous one-size-fits-all.
Very good. And I'm honestly very, very impressed to see so much activity in the neuroendocrine tumor space. There are 5-6 different programs. I wonder how many different radioligand therapy concepts do we really need in neuroendocrine tumors. But Simron, I'm not nasty enough to ask you this question. I'm asking you rather, what can we expect from combination therapy on one side? And the other side, you talked about the competitive landscape. And there's obviously also still the dream of immunotherapy, the dream of ADCs or T-cell engagers. How do you see the next 1 to 3 years changing there based on these things I just mentioned?
Look, as you mentioned, Ken, it is a very exciting time in neuroendocrine tumors. It wasn't that long ago where we didn't have a single phase 3 trial in neuroendocrine tumors. And, the NETTER2 is just another example. We had the cabozantinib trial after NETTER2 published in New England Journal, which had nothing to do with radioligand therapy, but still very exciting. So I think as we move forward, we are going to be thinking about combination therapies. There are a few, especially, the world of immuno-oncology has changed the landscape in many cancers, melanoma, lung cancer. Unfortunately, it really hasn't changed the landscape in neuroendocrine cancers. And I'm not really ready yet to write off checkpoint inhibitors in neuroendocrine cancer. I think combination therapy, there's many ways of even thinking about abscopal effect of the PRRT maybe itself could potentially help with immuno-oncology. There are some trials, especially out of the Australian group, that have been very interested in combination with chemotherapy. Unfortunately, the toxicity has been somewhat higher. And so I think we need to look at cautiously about what that might look at. I know there's been the Rotterdam group. They're about to publish their results, I understand, after a long delay in terms of radiosensitizers and how that might look with radioligand therapy. So I think, I'm open to the idea, but we do have to keep toxicity in mind in terms of combination therapy. And then there is this whole new area of antibody drug conjugates, BiTE therapy, et cetera, that's coming forward. I think we'll be looking more for those in the neuroendocrine carcinomas, the more aggressive that unfortunately lose their SSTR expression. So I think there's going to be room for them all moving forward. I think what might also be useful, as we've sort of alluded to, is trying to understand these neuroendocrine tumors better so we can pick the right treatment for the right patient at the right time. I completely agree with Lisa. I think we probably underutilize FDG imaging right now, and certainly there's a number of groups that we're trying to push forward on this to help us go beyond the traditional ways that we think of neuroendocrine tumors and integrate the different radio imaging ways to be able to better understand the tumor biology, add that with the patient characteristics, and then be able to find the right predictive factors that will help us figure out individually for these patients what is the right treatment for them.
This is a perfect transition to my last question, actually, Lisa. Tell us a little bit how you, with your vast experience and your big practice, how do you use somatostatin 2 receptor PET for response monitoring? And then when do you use FDG? What do you recommend when to use FDG PET?
So to me, the concept is clear. We are treating somatostatin receptor expressing disease, and we should see what happened to that octreotide avid disease. So, and we know that morphologic criteria are limited in response assessment because the radiation response is a slow process, which involves radiation inflammation and swelling of the lesions, which frequently result in what we call the pseudoprogression. So dotatate or DOTATOC PET-CT helps understanding the situation. However, at this time, there are no response criteria that are validated. So it is apparent, however, that a global all-lesion approach should be used in neuroendocrine tumors because this is similar to what happened also with PSMA experience. Again, we learned from prostate cancer radioligands with what has been done with the RECIP criteria. So it is the volume of disease that correlates with the progression-free survival and the overall survival, and the SUV also has a different meaning. So we also, with Dr. Weber and a grant of the United Research Foundation, we are conducting a study to define this response criteria of dotatate PET-CT. And when to use FDG. So technically, FDG is not a diagnostic tool to determine the extent of disease and to follow patients over time because neuroendocrine tumors are generally heterogeneous or non-FDG avid, but it's a great prognostic tool. And FDG avid disease tends to recur much earlier after PRRT or other treatments. So also FDG PET-CT can help excluding patients from PRRT who may bear SSTR negative, significant SSTR negative disease. Also, it may help identifying lesions with aggressive features that might be amenable for biopsy.
Just to add to that, though, I think it's not only for those patients who are SSTR negative, it's also for those who are SSTR positive, and for using, we may be able, there's been, one of our former fellows here, David Chan, has done some wonderful work on discordant lesions and the number of discordant lesions, tumor volume. We just published out of Toronto in JNM last month in September, a very small review that we did here with our patients looking at FDG and gallium. So I think this, again, will help us not only understand who are the right patients for RLT, but maybe there are select lesions that we can use external beam radiation on. Maybe there's other ways of treating those tumors, and you have that dual. Maybe something like you had mentioned about a combination approach. Maybe it is a 1-2-step approach rather than a combination approach. Yeah.
Absolutely true. I fully agree with you. And on top of this, we implemented PROMISE, as you know, for prostate cancer. I'm actually very much stressing my residents to work on NOMIS, that we have a standardized way to report somatostatin 2 receptor PET, which could be actually the base of exactly what you just mentioned. Well, we already spent 27 minutes, 28 minutes actually on just neuroendocrine tumors. We could easily spend 20 more minutes, but this would potentially bore out our listeners. That's why thank you all very, very much for joining. And again, I'm very optimistic that eventually we will come back with NETTER-3 or even compete and compose to discuss this very, very soon again. Thank you both very, very much. It was a great pleasure to discuss with you.
Thank you.
Thank you.
Thanks for watching, and thanks to Sophie Biosciences for sponsoring this episode. Please remember to like and subscribe.